Good afternoon, all. I'm presenting on behalf of Medicine One. My topic is Butterscotch. History. Mrs. M, 61-year-old from West Bengal, presented with the fever for 2 days. And history of presenting illness, she had high-grade fever, documented 104 degree Fahrenheit for 2 days, and intermittent in nature associated with the chills and trigger. With the baseline health status of, she gives a history of slip and fall from the chair 2 months back, following which she became bedbound due to low back pain, and she is dependent for activity of daily living. She developed pain in the right hip for 2 weeks, which was dull aching and radiated to the right leg, aggravated activity and related by hip flexion. She was evaluated outside for hip pain and started on steroid and NSAID. No significant past and personal history, and the examination wise, patient vital was stable, and pallor was present, and pededema, pitting pededema subdural angle was present, and oral thrust was present, and systemic examination no abnormality was detected, and local examination the right lower limb attitude was flexion at hip and knee joint, and there is a leg raising test and Fabus was negative, and so as signs was present. There is a right lower quadrant pain with a passive hip extension. So to summarize, the 61-year-old female with acute febrile illness presented with the background of low back pain followed by the trauma. The differences were considered was psoas abscess and psoas hematoma and appendicitis as a retrocecal and renal colic and vertebral osteomyelitis and malignancy. So investigation, so hemoglobin was 6.45.
But that fall was some time back, no?
So
the fall was about 2 months.
2 months back. Sir. After that, patient bedbound.
Okay. Is there some? Sorry, I didn't get it. It was a weight loss, some systemic upset, nothing. Otherwise, well.
Yes, sir. Investigation, the WBC was 44,500 and with the neutrophil of 81%, and peripheral smear also shows that there is a neutrophilic leukocytosis with the toxic granules was seen, and anemia workup ended up with the iron deficiency, and liver function and renal function was normal, and there's a mild hypokalemia and hyponatremia was noted, and BPS was negative, and CRP is 329. So started with the imaging was done, and it shows that there's a large heterogeneous hypoechoic lesion in the rising from the right psoas muscle, the ultrasound abdomen, and the further imaging CT abdomen was done. It shows that the large heterogeneous collection as noted in the right iliopsoas muscle extending from the L2 vertebral region to the pelvic. And there is a association with the L4, L5 this vertebral distraction in the upper right edge of the vertebral body and suggestive of infective L4, L5 spondylodiscitis. Blood culture was done.
Don't worry about that. What do you think would be the etiology here?
Most probably staph streptococcus.
Okay, staph is possible. Streptococcus. Anything else?
E. coli.
Unless there's a UTI unusual. Milioid is something we would worry. Not a diabetic, but that's something. TB?
It's a cold.
2 months history. Maybe that's possible, isn't it?
The blood culture was done. It's grew Streptococcus constellatus as a and a sensitivity was done as a sensitivity to vancomycin and cefotaxime. And USG gated abscess drainage was done with the pictal catheter and samples sent for culture, and the culture was grow Streptococcus constellatus. So I'd like to briefly about the Streptococcus angiogenes group. It's a gram-positive Streptococcus grouped in chains and consists of Streptococcus intermediate and constellatus and anginosus, and known commensal for upper respiratory and digestive and reproductive tract. The small colony is tiny colonies was gives of the distinct odor of butterscotch or caramel. A risk factor, so commensal in the upper GI tract. So it's the aspiration most common respected. And apart from that, there are direct implantation from the trauma and surgery and extension by the continuity and hematogenous spread and neoplastic disease and periodontal disease and diabetic mellitus and apparatus and achieved. So some pathophysiology as shows that
I don't think anyone would benefit. Pathophysiology. Go to the other things.
So most commonly the Streptococcus constellatus and intermediates is associated with the pleuropulmonary and soft tissue abscess, and the anginosis is more commonly isolated from the blood and urine. These are the sites where the Streptococcus anginosus group infection produces, it leads to abscess. Mostly the head and neck and abdominal cavity, liver abscess and GI tract abscess, and soft tissue cellulitis and osteomyelitis, and subcutaneous and muscle abscess. Streptococcus, these are the samples from the various cultures shows that there is mostly the X-rayed aspirate or fluid mostly is grow Streptococcus constellatus, and blood cultures was mostly was Streptococcus angiogenes. And this classification, the abscess was more common in Streptococcus constellatus. As a soft tissue abscess, 13 cases was reported as a soft tissue abscess, and other intra-abdominal and pleuropulmonary abscess also mostly due to Streptococcus constellatus. And this is minimum inhibitory concentration. It's mostly sensitive to the penicillin group and macrolide groups and vancomycin. So there is a pan-sensitive organism. Well controlled with the antibiotics. There are some like I never go for a Streptococcus constellatus, and they are well treated with the antibiotic and well responsive. And treatment, so antibiotic for 6 weeks for our patient as an injection vancomycin was started, followed by oral changed into oral amoxicillin after the follow-up USC screening and surgical intervention. So indication for the surgical intervention was neural compression and extensive bone destruction and severe pain that is difficult to deal, and epidural abscess and failure of the conservative management. Thank you.
Any questions to him?
Highlight this.
So after that patient had a bed bone, there is some osteomyelitis. So trauma leads to abscess extent.
Any associations between trauma
Yes,
and
development of psoas abscess.
So your theory is that the entire thing is miliary group strep.
Sure.
The spinal infection plus psoas abscess, everything.
Yes, sir.
Why do you think he was not febrile then?
So initially acute, presented with the acute febrile illness.
No, he didn't present with acute febrile illness. Leave that term. That has a different connotation, like scrub or something like that, isn't it? But if you say that he started with a bone infection plus a psoas collection, then my question is that why was he not febrile? So keep that in the back of your mind, because these are very virulent pus-forming organisms, and usually we see it with visceral abscesses, muscular abscesses in somebody who is a bit moribund, like your patient. But they don't take usually 2 months to present to you. And bone infections can happen, but they are rarer. So one of the other things to think about is there something else going in that bone, and this sort of seeded it. The other thing, his HB is very low. Why is he so moribund? You also put up, all these are gut dwelling organisms.
Yeah.
So if you have a malignancy, you worked up for it. Is
Worked
it?
up for it.
Okay, excellent. Go on, tell us about that.
So we work up for a gastroscopy was done, and it shows that gastric edema, sir.
Sure.
And after that, we discharge the patient, plan for a colonoscopy.
Sure.
To any breach.
Just complete that.
Sure.
And also maybe good to go back and see how well he has healed, yeah, after 6 weeks. Why did you use amoxicillin clavulinate? Not happy to use amoxicillin? Is there a beta lactamase production in these organisms?
No, sir.
No, they don't, they are very susceptible organisms, isn't it? So you could get away with amoxicillin itself. You're just adding another agent.